You leave the door open or?
We always keep it open. You can't close it.
خلاص. طيب السلام عليكم ورحمة الله. Need to stand here, sorry. يعطيكم العافية بنات، يعطيكم العافية شباب. Okay. أنا my name is دكتورة منال عالم, and I will be teaching you some lectures in the POD blog. And one of the actually basic lectures that you need to know in your pharmacology, and you learn them by heart, is the autonomic nervous system. Because once you know what is the normal physiology and how your autonomic nervous system is functioning, then you can relate or understand a lot of drug groups that are working on the same receptors. Okay, you had the introductory lecture, and you were introduced to what is the basics of having two divisions of the autonomic nervous system, the sympathetic and parasympathetic. And usually when we start these lectures, we cover first the parasympathetic nervous system and then the sympathetic. And that's why today, inshallah, I'll try to cover cholinergic agonists and antagonists. Because you need to understand, so I hope that every slide, I'll explain it to you, and I hope that you are following with me. If you have any questions, don't worry about the time. If you are actually short of time, I'll try to find a solution. Either I'll record something for you or anything. But the most important is that you are following with the flow of the lectures. When we say cholinergic agonist and antagonist, I'll just revise 2 slides for you to remind you about the introductory lectures. The nervous system, as you have covered, is classified in your anatomy into 2 important components, which are the central nervous system and the peripheral nervous system, right? But if you are talking about body functions, then you need to classify it differently, and we need to classify it by, depending on the function, into a somatic and autonomic nervous system. And what is the somatic basically? Is the one that is involved, it's the one that you can control. It's the nervous system that you involved in the voluntary control of the skeletal muscles and locomotion. This is the thing that you can control yourself, but you are not in control of the speed of digestion of your meals. You're not in control of the heart rate. You're not in control of your blood pressure, isn't it? So these are the body functions, or the essential body functions, that are under the autonomic nervous system control. So this is the involuntary regulation of body functions. And you have covered that we have afferent neurons and we have efferent neurons. And the efferent neurons in the somatic is different from the autonomic. Most importantly, in the autonomic nervous system, that we do have our anatomy and the function divides the efferent neurons into 2. Okay, we have the first nerve cell, or we call it the preganglionic neuron, and we do have the second nerve cell, what we call as the postganglionic neuron. Why? Because there is an autonomic ganglia in between, which is a collection of cell body outside the nervous system. So basically the signal will be taken by 2 steps before it reaches the effector organ, whether it is a sweat gland or a gastric gland or salivary glands or whatever, right? What is the situation in the somatic nervous system? Do we have like this mediation, autonomic ganglia? No, it's a single myelinated fiber that travels from the CNS to the skeletal muscle, okay? So depending on this structure, which one you think is working faster? Yes, okay. So the autonomic will take time, right? So if you, and subhanAllah, this is for the purpose. If you see something, for example, dangerous and you want to escape from, if there's a fire and you want to escape, you need to escape within seconds or minutes, صح? So you will do the voluntary control of your skeletal muscles very, very quickly. But if you eat a meal, for example, how long does it take you to digest that meal? This is the autonomic, صح? Yeah, so the regulation or the processes under the autonomic will take time accordingly. Now, this this figure actually helps you when you study the autonomic nervous system, whether you're talking about parasympathetic or sympathetic. The first two rows that you can see are the classic representation of the cholinergic transmission or the parasympathetic nervous system, and the one next is the sympathetic nervous system. So these two are the classic representation for what is happening. But then you know that you have some exceptions to the rule, right? Either different neurotransmitter or something that there must be something that's um, considered as an exception from the normal circumstances. Okay, when we want in the parasympathetic nervous system, let's take it for example, if I want to classify that neuron, I will classify it based on the fact where is it located in relation to the autonomic ganglia. Is it before, okay, where the cell body actually originates from the CNS, or is it actually coming after the autonomic ganglia, where the cell body is there and the neurons are, or the axon are traveling away from it? So we can say preganglionic or postganglionic, okay? And then depending on the anatomy, does it belong to the sympathetic or parasympathetic nervous system? And then what is the neurotransmitter that it uses? You know that what types of neurotransmitter that we have for the transmission of the signal? We have acetylcholine. And if the neuron is using acetylcholine, what am I going to call it? Cholinergic neuron, yes. And if the signal is being delivered by adrenaline or epinephrine and norepinephrine, we will call them adrenergic neurons, okay? Okay, so based on this knowledge, what is that? This is a preganglionic, parasympathetic, cholinergic, because it releases acetylcholine. And what is that? Postganglionic, parasympathetic, cholinergic neuron. Okay, that's the basic thing in parasympathetic nervous system. What's the basic thing in the sympathetic nervous system? I have a short preganglionic, sympathetic, cholinergic neuron because it releases acetylcholine to the autonomic ganglia. And what is that? Postganglionic, sympathetic, and releases epinephrine, so we call it adrenergic. Okay, what is the exception here? Sweaty glands. What is the exception, the sweaty glands? Yeah, so the postganglionic sympathetic neurons, they do not release adrenaline, they release actually acetylcholine, right? So that's why sweaty glands is one of the organs that will be sort of stimulated by both systems, okay? Whether you're talking about sympathetic stimulation, you will actually sweat quite a lot, or there is some sweating response. If you're talking about availability of acetylcholine, similar molecules, then again, they are going to work on the sweaty glands because this is their target. That's the exception, sweaty glands. What is the exception that we have in the renal blood vessels? عفوا.
Can you use the pointer in the computer because of the people so they can't see
عفوا.
actually.
Okay, طيب. Okay. What is the exception in the renal blood vessels? Yeah, the postganglionic sympathetic neurons are using dopamine, which is another neurotransmitter that belongs to the sympathetic nervous system. What about the adrenal medulla? Yes, so basically they would not have a distinct post-ganglionic neurons, you know, somewhere. They will secrete immediately. You can consider that the post-ganglionic neurons are within the adrenal itself, so they will secrete the epinephrine, norepinephrine directly to the bloodstream. Okay, so good. So you are quite prepared to progress. Now, where are the cholinergic neurons that I will be talking about? All preganglionic, whether I'm talking about sympathetic or parasympathetic, are actually cholinergic because they release acetylcholine. Okay, what else? All the postganglionic, parasympathetic fibers are again, they are cholinergic. And remember sweaty glands, yeah? Although that they are actually having sympathetic supply and it's only sympathetic supply that they're receiving, but the neurotransmitter that actually acts on them is acetylcholine. Do we have cholinergic neurons somewhere else? Yeah, the somatic nervous system actually. That we said a single myelinated fiber that comes from the CNS back to the skeletal muscle. It will release what at the motor end plate? Acetylcholine. So don't forget that in our lectures, somehow somatic might be involved or skeletal muscles might be involved with us. What about cholinergic neurons in the CNS? Cerebral cortex, okay? We still have cholinergic neurons in there, okay? And we do have actually, they are both muscarinic as well as nicotinic with different subtypes. And acetylcholine centrally is very important neurotransmitter, it's very important excitatory, and it is important for us to learn. It's important to have memory, to for the reward process itself. So it's very, very important neurotransmitter for learning. What happens if somebody has got degeneration of those cholinergic neurons centrally or do not have adequate acetylcholine to work on them? Have you heard about Alzheimer dementia? Okay, so the known so far pathogenesis of Alzheimer dementia that there is some degeneration in the cholinergic neuron centrally. If we need acetylcholine to learn and to memorize and to to educate ourselves and be alert, unfortunately we're going individuals with dementia will lose that. They are not actually remembering and they cannot learn new information. Okay, acetylcholine now. There are 6 processes. I think you covered these with Dr. Dilip. صح? Yeah, so we have synthesis, storage, release. So I'll go over the key component. Choline combines with acetylcholine, okay, in the presynaptic neuron itself, and then with the help of the enzyme choline acetyltransferase. This is the enzyme that we need in order to make choline. And where do we get choline from? It's an important component in the cell membrane itself, in sphingomyelin and phosphatidylcholine. Okay, and acetyl-CoA is an important metabolic molecule involved in metabolism. So we use this enzyme in order to make it. Once we make it, we store it in synaptic vesicles. And it is ready in the presynaptic neuron or cholinergic neuron that we're talking about. Once action potential comes, what will happen? With the calcium entry, it will cause fusion of the synaptic vesicles, as you can see here, with the cell membrane, and accordingly it will release acetylcholine to go and bind with its postsynaptic receptors. Okay, now there is actually a certain process important, or there is a drug that I would like to talk about before we continue, which is botulinum toxin. You have taken in your microbiology a bacteria called Clostridium botulinum and the disease botulism. Okay, uh, this is why it causes advanced muscle weakness and paralysis and ptosis and diplopia and difficulty in all of that. Yeah, because the toxin that is produces, which is the botulinum toxin, can cause, it interferes with acetylcholine release from the cholinergic neurons, okay, at the motor end plate. Okay, we're talking about somatic now. Okay, so how does that? Yeah, and some people trying to investigate that there is a certain protein called SNAP, or abbreviated as SNAP. You don't have to worry about the mechanism. Just know that it interferes with acetylcholine release, because this is SNAP25 is an important protein that helps with the fusion of the vesicles with the cell membrane to release acetylcholine. So basically, they will go once you that then neurotoxin will go inside, will undergo internalization, go to the cytoplasm, and then cause a cleavage of that protein, interfere with it, and will not be able to cause this fusion of the vesicles with the cell membrane and releasing acetylcholine. So we are somehow with the botulinum toxin interfering with the release of acetylcholine. Okay, so knowing that, in 1989 they started to use botulinum toxin after some purification for some therapeutic purposes. Whenever you have a case of a certain or increased muscle contractility or severe sort of yeah, exaggerated response than what you need, okay, then you can use botulinum toxin after its purification. And this is Botox, basically. So the first indication for it is strabismus. Do you see this? Strabismus, What is the problem here? Where is the problem? In the right eye or left eye? In the right eye. You see the right eye is a little bit crossed. It's not, the strabismus means it's a lack of proper alignment between the two eyes when you look into a certain direction, okay? If I'm looking that direction, they should both looking and the sort of, you know, my eyes are aligned together and the same position, okay? It's not like this one. He's looking straight forward, but the right eye is looking as if that there is an object to the left. And this is because of disbalance between the power of the muscles that are controlling the orbit, okay? So here there must be, this muscle might be stronger than the lateral. Say for example, internal rectus and lateral rectus, okay? So one of them, if it is stronger than the other, it's going to pull the eye. It's not, the eye will not be in the center. This has got ophthalmic visual problems as well as cosmetic, okay? So they start to inject the muscle with a little bit of Botox, okay? And then it becomes weaker, balances the other muscle, and then the position of the eye becomes correct. واضح شباب? Okay, so that's strabismus. The second indication is blepharospasm. Blepharospasm, sometimes there are certain individuals with unknown, sometimes it's a benign condition where there is involuntary closure of the eye. They cannot just open their eyes because the orbital muscles are actually contracting too much. So they need to inject Botox around these muscles to relax and open up the eyes. And then it started to be used for hyperhidrosis, excessive sweating. You know that sweaty glands, we know that it receives sympathetic supply only. But since it is using acetylcholine, then I can, in the armpit or in palms and soles, wherever the excessive sweating is, we just can infiltrate that region with Botox. And the half-life is 3 to 4 months. So he will not need to repeat the injection before, yeah, and it's quite actually long acting. So it's very, very, very good. And that saves a lot of money and invasive procedure. Migraine, again, it is the muscles are injected. Cosmetic, of course, but all of you, you know, sometimes any muscle that is contracting more than what is needed, then they can inject it with Botox and make it relax, okay? Back now to acetylcholine. The normal physiology, once it's released, will bind with receptors called muscarinic and nicotinic receptors. You know the names? Good. And once it binds, not only that, there is something called presynaptic receptors. What is that? That means the cholinergic neuron that is releasing a certain neurotransmitter, whether it's sympathetic or parasympathetic, that neurotransmitter will go to a postsynaptic receptors. This is what we know. Sometimes it goes back to the neuron that has released it. And there are certain receptors on the cell membrane, okay? Why it needs to go back? Because, yeah, it will tell the neuron, depending on the physiology and what is going on, if that neuron needs to release more or need to release less, or just continue with the same rate. But this is, subhanAllah, very, very beautiful mechanisms by which there is some regulation that happens. What is the enzyme responsible for acetylcholine degradation? Yes, okay. It will do that very quickly within 5 to 20 seconds. And then choline is being recycled and taken back by the neuron and can be used back. What is the difference between muscarinic receptors and nicotinic receptors? The muscarinic receptors are G protein coupled receptors. So there is a secondary messenger. Nicotinic receptors are ion channels. Yes. So which one again more fast? Nicotinic. And that actually complement what we have said about this difference between somatic, because somatic needs actually very quick ion channel opening and ion and electrolyte going inside the cell. Now you might be wondering why we call them muscarinic and why we call them nicotinic receptors. Huh? أيوة. She said that nicotinic receptors are activated by a substance called nicotine. صح? And muscarinic receptor is activated by a receptor called muscarine. عفوا, a substance. Yes. So we call that receptor. طيب do I have muscarine and nicotine in my body? طيب why do I need to call that receptor after certain substances وأنا عندي acetylcholine؟ صح؟ Okay. The reason why is we have two reasons. When they were developed and when they were discovered. Okay. Muscarine is the first parasympathetic agent discovered on Earth by scientists. They were discovered in 1869, 18 سنة, okay, 69. So it was known to be a substance that activate some receptors somehow in the body, okay, and produces certain effects, okay? So muscarine, and where is muscarine is coming from? From toxic type of mushroom. This is where muscarine is coming from. And nicotine is the active ingredient from tobacco. And tobacco has been known since the 17th century, ages ago. People used to smoke some tobacco, okay? So knowing these substances, they were there and known before we discovered that these receptors are made, subhanAllah, to bind with acetylcholine. Look at the time when we discovered acetylcholine, 1929 only, right? So like maybe 100 years قبل ما نعرف إن أساساً these receptors were meant to interact with acetylcholine. So we discovered muscarine nicotine before acetylcholine, basically, okay? And look at the affinity here. This is important. They have stronger affinity than acetylcholine. So in case your body is being sort of intoxicated by nicotine, for example, it will fight or it will compete with your acetylcholine and it will get and it stimulate these receptors, okay? So affinity, again, is an important issue. And for that reason, we kept naming them muscarinic receptor and nicotinic receptor. واضح السبب? Okay. How many subtypes we have? Muscarinic, we have 5, M1, M2, M3, different body organs. Like, for example, M2 in the heart, M3 in the glands, okay? You do not need to worry about this subclassification. Nicotinic receptor, we have only 2. One in the autonomic ganglia, we call them neuronal type, all right? And one, we have them in the, neuromuscular junction or the motor endoplate. Excellent. So now the cholinergic agonists, we have direct and we have indirect. When we say direct, they are basically structural analogs, or they are similar to acetylcholine, and that's why they will go to acetylcholine receptors and stimulate them, as simple as that, okay? And the indirect will do something different, but we'll see that. So when we say direct, we have 2 groups under that. Esters of choline and alkaloids. When we say alkaloid, that means it's a naturally occurring chemical compound that has got a basic nitrogen atom. Most importantly, that alkaloids available in nature are highly lipid soluble. Okay, so that means the absorption from any route is going to be much easier, and you need smaller dose to achieve a certain therapeutic target. But when we say esters of choline, these are quaternary ammonium compounds. Any compound that has got quaternary ammonium compound or the ammonium compound is positively charged. Any positively charged substance is going to be less lipid soluble, okay? And accordingly, the absorption or availability for oral use or oral preparations are going to be less likely or shorter half-life, or I have to give a bigger dose to achieve a certain therapeutic range. Under the esters of choline actually falls acetylcholine itself. We have methacholine, carbachol, and butanochol, all right? And under the alkaloids, we have the naturally occurring chemical compounds, as I told you, muscarine and nicotine. And there is one drug that actually is similar to them, which is pilocarpine. Okay, let's take acetylcholine. It works both on muscarinic and nicotinic receptor, صح? You remember from this, هنا, صح? Acetylcholine is equally acting on these receptors. However, it is very, very susceptible to cholinesterase, and that's why the half-life of acetylcholine is only 5 seconds or 20 seconds, very short acting, because it's very highly susceptible to being broken down by the cholinesterase enzyme, okay? If you want to develop drugs, they must be more longer acting. يعني there is no drug that we can give 5 seconds, صح ولا لا? So we need actually medications or drugs that we develop to be more longer acting. And that's why methacholine, carbachol, butanochol, It's not required from you to know the half-life, but it's about an hour, okay, and which is a great progress when you compare that to 5 to 20 seconds, of course. So why they maintain, or why they have a longer half-life? Because they are not susceptible to the breakdown of cholinesterase, and they will be broken down by liver enzymes or whatever. When you choose them, when you choose a certain medicine, you need to know which receptor you want to act on. Methacholine, for example, it works on muscarinic, but no effect on the nicotinic receptors. Carbachol can work in both, and bethanychol can work in muscarinic and not nicotinic receptor. And even when we say muscarinic receptor, uh, they might be a preference to a certain subtype, more on the glands, more on the GIT, more on the heart, something like that. Okay, this is the organ effect of the direct acting cholinergic agonist. Or that's the table basically to explain to us what acetylcholine is doing in our body, right? I, CVS, respiratory, GIT, genitourinary, and glands, all of this is muscarinic, through muscarinic receptors. And centrally, we have nicotinic as well as muscarinic, and neuromuscular junction at the bottom here is only, طبعا, nicotinic receptor, okay? Let's see now what acetylcholine is doing. First of all, in the eye, it is going to cause contraction of the pupillary constrictor muscles, and that will cause miosis, okay? And the second effect, contraction of the ciliary muscles, and this is accommodation, or making the eye lens suitable for reading. And both of these two will facilitate the aqueous humor flow. Do you know what is the aqueous humor? What is the name of the fluid in the eye? Aqueous humor. Okay. Have you heard about glaucoma? الماء الأزرق? Anybody knows what's glaucoma? طب ما تعرفونه بالعربي المويه الزرقاء حد يعرفها what is it? It's increased intraocular pressure, because this aqueous humor that we're talking about, this fluid is building up without proper drainage. Okay, let's see now what happens. And I like to use diagrams. The size of the pupil in our eyes is controlled by two types of muscles: pupillary constrictor muscles and pupillary dilator muscles. Okay, and from the name, constrictor, that means they will constrict, and dilator, they will dilate. How they do that, it depends on the anatomy of those smooth muscles, okay, of the iris. So if the pupillary constrictor muscles, these are circular muscles. Do you see the blue arrows? This is their alignment. So they are aligned in a way that they are circular. If they contract, what will happen? Yeah, the pupil becomes smaller because the contractility is shorter. They will become shorter, okay? So this is actually more of a function of parasympathetic nervous system, or acetylcholine. Look at the pupillary dilator muscles. These are radially arranged, يعني زي الشعاع كده, okay? Do you see them? The blue arrows is pointing to them. What will happen to them when they contract? When contract becomes shorter, so they will open up the pupil, and the diameter is going to be bigger, okay? So normally our pupils are controlled by both parasympathetic and sympathetic, okay? Dilator and constrictor. Which one is dominating? So if we're having parasympathetic dominance, then the pupil is going to be small, and sympathetic, then the pupil is going to be big, okay? So this is the pupillary constrictor muscles by which acetylcholine is working and causing a small pupil, or miosis. Okay, look at this. This diagram shows you how the aqueous humor circulates inside the eye. Okay, it is secreted here from the posterior chamber by the ciliary. هنا اسمه مكتوب هنا مكتوب بالواقع ciliary body. The ciliary epithelium on the body itself secrete aqueous humor. So it is secreted from the back of the eye. It needs reabsorptions from here in the anterior chamber. So it needs actually to go, this is the lens, this is the iris, and this opening is the pupil, صح? It needs to go with the black arrow from the posterior chamber back to the anterior chamber. This is where it is being reabsorbed from the trabecular meshwork, and then it goes to canal of Schlemm. Okay, it is coming from blood and then reabsorbed back to the blood. Okay, so this process of secretion and reabsorption, it has to be very nicely, in timely manner. It needs to be regulated, because if there is so much secretion and reduction in the absorption, it will lead to glaucoma. This is the disease that I asked about, because increased intraocular pressure. There's so much pressure inside the eye because of aqueous humor. Okay, so knowing that it goes this way, this is important because it says if you make the pupil small or if it produce meiosis, it will increase the drainage. How is that going to be? Do you see the iris here? Okay. If if we have meiosis, what will happen? It will be pulled to the center, صح? And it will open up this angle. That's what I want to say. If you produce meiosis, okay, the iris instead of this, it will become contracted and brought to the center. So حيفتح الانgle. Okay, so it will open this angle for us, and that will help with the aqueous humor reabsorption. Again, when the ciliary muscles are contracting and making your eye suitable for reading, the eye lens, what is the shape that will happen to it? Accommodation reflex في الeye. خدتوه في physiology. The eye becomes more convex, more to the center. And they say that actually bringing the lens to the center and becoming more convex for reading, again, it will open this actually pathway. So we're basically talking about two mechanisms by which we are enhancing the outflow of aqueous humor and facilitating it to reach the site of reabsorption. So does that help in glaucoma or not? Depends on age. Yes, yeah, basically. Or if somebody has got glaucoma or increased intraocular pressure, you will study cholinergic agonist as one of the actually most important group of drugs, okay, by causing this meiosis and contraction of the ciliary muscles for accommodation. That opens it's like a geometry kind of changes that happens. Okay, what will happen to the heart with the parasympathetic nervous system? Slow heart rate by affecting the SA node, which is the chronotropic effect, where actually this is where the control or the generation of impulses starts. And AV node is responsible for conduction, صح? So this is a dromotropic effect. It's going to inhibit both, so we will end up with having lower heart rate. Force of contractility of atria and ventricles, reduced, exactly. Respiratory, the bronchial smooth muscles, they're going to contract with acetylcholine. So the diameter is going to be narrower, okay? Secretions all over the body is increased by acetylcholine. Okay, so even the bronchials in the goblet cells or whatever inside the tracheobronchial tree, they will secrete so much. GIT, secretions of everything, starting from saliva. Okay, لا خليها مع الجلاندز هتكلم عنها. في الجي اي تي what will happen to the motility of the smooth muscles in the gastrointestinal tract? Increased. What will happen to the secretions of the gastric enzymes in general? Increased. And what will happen to the sphincters? Relaxed. Okay. Genitourinary, it's again the detrusal muscles of the urinary bladder will contract, and the trigone and urethra is going to relax, and that will facilitate urination. Other glands, all of them, sweat, lacrimal, nasopharyngeal, all of them will increase their secretion. Okay, why? Because the parasympathetic nervous system, in order to help you to learn this table, it's rest and digest. صح? We know this, okay? So you need to rest. That's why you don't need a very fast heart rate or force of contractility and high blood pressure, right? Because you are just resting and you are digesting your food and you are excreting the waste products. That's actually what means by rest and digest. CNS, acetylcholine is very important neuromodulator. This actually effect of acetylcholine on the alertness and learning process, it's not by only acetylcholine, but it interacts with cholinergic signaling is a complex actually phenomena by which it involves glutamate and dopamine and other neurotransmitters. Neuromuscular junction, طبعا we know that acetylcholine and slightly nicotine is going to produce depolarization of the endoplate and muscle contractility. Okay, واضح هذا الكلام؟ Because when we study cholinergic antagonist, we are going to نعكس هذا الجدول كله. تمام? Excellent. Yeah. Now let's look at the indirect acting. يعني احنا in this table we have taken, this is the effect of acetylcholine, and if methacholine, for example, is working, or pilocarpine, or the other drugs that are working directly on acetylcholine receptors are going to affect or produce similar effect, or يعني in a way or another, right? But when we say indirect acting cholinergic agonist, what do we mean? Yeah, yeah. So they are not actually similar, very similar to the structure of acetylcholine, will not go to its receptor. No, they are actually going to interfere with the enzyme responsible for acetylcholine breakdown or metabolism, because it's at the synaptic cleft where you will find choline strays waiting for acetylcholine to be released. It will give it a chance of seconds to produce its activity and then to break it down to choline and acetate. Okay, so these drugs are going to cause what? They will make a complex binding with the enzyme. If the enzyme is being bound with something, it cannot work efficiently. And accordingly, what will happen to acetylcholine? Increased bioavailability of acetylcholine and buildup. Okay, excellent. We have three chemical groups under which these drugs. طبعا you're not required to know the chemical group, but I put that for you because I want you to know why they are different. And there is significant differences between them because the structure is different. Okay, the first one is hydrophonium. Hydrophonium actually under a group called quaternary alcohols. So these are simple alcohol and has got quaternary ammonium group. Okay, so do you expect it to be highly lipid soluble or not? From what I've just said. فين yes أنا قلت quaternary ammonium. Less, yes, exactly. So it is less lipid soluble compared to other things, and that's why hydrophonium is less lipid soluble. When we say carbamate esters, these are esters of carbamic acid. That's a different group in their structure. And again, esters of carbamic acid, they are not actually highly lipid soluble, all right? But when I put asterisks here, this asterisk that you can see, it means that this drug is an exception to the group. So what do you expect physostigmine to be? Yeah, highly lipid soluble. Okay, excellent. And when we say organophosphate, these are organic derivatives of phosphoric acid. This is a completely different group. And again, it is highly lipid soluble. But this drug in particular, icothiopate, is less lipid soluble. So it's like a polar compound, all right? But this is actually the medicines. Hydrophonium works for 15 minutes, neostigmine for 4 hours, and pyridostigmine up to 6 hours. Physostigmine is 2 hours. And icothiopate has got a very long half-life, and that's why we do not like to use it. You do not like to use anything that works for 100 hours. It's too long for actually titration or reduction in dose. But I will tell you in which situations we might be using it. Okay, look at this type, this column basically. Okay, we have carbaryl, we have soman, sarin, parathione, and malathione. What are these? These are actually chemically related to the group that's actually opposite to it. But these are not medicines. These are developed to be something, to kill a living organism, okay? So basically you can kill insects by insecticides, you can kill people by nerve gases or nerve agents. واضح? Okay, so these are actually, this is the classification. Now, I've told you that carbamate esters, they are polar, okay, and this lipid soluble with negligible distribution to CNS. Physostigmine is an exception, and it has actually very lipid soluble, can reach CNS. Organophosphates are well absorbed from every route of administration. Why we need insecticides and why we need nerve agents to be highly lipid soluble? Yeah, because if you are a farmer, for example, and your farm has got rodents or lizards and insects, and you want to kill them, Are you going to give them something that they need to eat first and then die? Or you want something that you can spray from a يعني, a far away distance, and then that will kill the whatever يعني, insects that you're having? Okay, the thing that you spray from a distance and yet can be absorbed efficiently is the highly lipid soluble preparations. Okay, because they are going to be absorbed from the eye, from the bronchioles, from the skin itself. Okay, so that's why you just spray it from a long distance and it's going to kill that animal. The same principle that happens with the nerve agents. What do you know? No, what do you know about nerve agents? They are weapons of mass destruction, صح? They're used in wars to kill people. How they are actually sort of يعني delivered either by, sorry, yeah, and مش mechanism. Actually, you're either by blast, for example, or by atomizers. If sometimes they hear an explosion and then these are liquids and then change to vapor, and then the people will start to breathe them and then they will definitely die because they are made in such a way that they're highly lipid soluble. So even from they do not need to, for example, to get exposed to them or drink them. It's just by the exposure of the skin itself and the bronchial airways to them, then they are going to kill these individuals. Right? Now, why we have differences in half-life and differences in structure? What's the time now?
It's 9:44.
Oh, طيب. يعني we stop ناخذ
You want to stop lecture?
انتوا تبغوا بريك الان ولا؟
There are two lectures. But
ايوه yes.
So this is the first lecture is done ولا؟
لا لسه ما خلصناها. بس يعني ما في مشكلة whenever. Shall I continue بعدين ناخذ بريك ولا كيف؟ So tell me then when you want the break. Okay, so what is the difference and why the half-life of hydrophonium is different from neostigmine, different from ecothiophyte or organophosphate? Why they are different? Because the hydrophonium, we said that these drugs are going to make a bond with the cholinesterase. What is the type of the bond and how long it's going to last? This is the difference that actually makes half-life is different. Okay, hydrophonium is going to make a hydrogen bond, and hydrogen bond with the enzyme. And hydrogen bond, if you study your basic in pharmacology, this is the weakest bond. It's very weak and very short-lived, and it's going to be undergo splitting and will release the enzyme. So the enzyme will be back again to function. Okay, that's why they're working only for 2 to 10 minutes. But the carbamate esters, why they work for hours? Because they make a different type of bonds, which is covalent bond. Covalent bond is stronger and can last for 2 to 3 hours without being without undergoing splitting and releasing the enzyme. Once they release the enzyme will do its job and it's going to break down acetylcholine. Okay. However, in the organophosphates, which is we have only ecothiophyte, we use it as eye drops if we want, because it's very, very long acting. So we do not like to use it systemically. We can use it as eye drops in cases that we have a glaucoma, for example. But the organophosphate, once we make them as insecticide or as nerve agents, then you want actually a very long half-life in a way that the bond that you create with the enzyme is going to be very strong bond and undergoes a process called aging. What does that mean? It means that the insecticide will come, for example, and make the bond with cholinesterase. But within 10 minutes, aging will happen, especially with the nerve agents. And they're structured in a way that from the name, what do you understand from the word aging? Yeah, something becomes stronger and very resistant and very stubborn. This is what we mean. So the bond itself, it becomes stronger with time. After 10 minutes from making that bond, it becomes actually strong enough that you cannot actually break it down. Okay, and that's the purpose of doing such thing with these nerve agents, because the purpose is not to treat, the purpose is to kill. Okay, so you want to make sure that the enzyme is not going to be released back to function physiologically. Okay, and this aging happens within 10 minutes. If the exposed individual was lucky enough to have a hospital nearby, they can do something and they can treat and give the antidote. Okay, but the problem is, يعني, under which circumstances, in war circumstances, that somebody can have an access to hospital within 10 minutes. طبعا very very small chance, and that's why يعني, people die unfortunately. So this is actually the process of strengthening the bond between the two. It will happen with time. And direct acting cholinergic agonist, the one that I've just told you, the neostigmine and pyridostigmine, neostigmine, as well as the insecticides, as well as the nerve agents. Do you expect the organ effect for them is to be similar to acetylcholine? Huh? لا ليش opposite? Yeah, is it similar in magnitude, similar in, يعني, is this table supposed to be like the other one?
Maybe from the duration.
Yeah, long duration, yes. Similar in a way that they, يعني, they will affect different organs and produce something, yes. But you have to be prepared that this group, the indirect acting cholinergic agonists or cholinomimetic agents, include medicines and toxins, صح? So that's why there might be actually يعني, some difference in them. If you're using them as medicines, they will do something like acetylcholine. But if somebody is getting exposed to insecticide or a nerve agent, then you should be actually seeing the extremes and different features, صح? Okay, so the effect on the eye, respiratory, GIT, genitourinary, the same. The salivation, meiosis, okay, increase lacrimation, diarrhea, for example, increase urination, all of that is what we expect. However, there are effects on the cardiovascular and CNS, and that might be actually responsible for somebody with the fatality that happens in these cases, because it's very important. Somebody will die that the heart and the brain is being affected differently. What will happen to the heart? We know that the heart, once there's actually so much acetylcholine, there will be bradycardia, and there will be reduction in force of contractility and reduction in cardiac output. This is what we know. However, you might see some individuals who are having a rise in blood pressure through vasoconstriction and a rise in the sympathetic systemic vascular resistance, SVR, or peripheral vascular resistance. Sometimes you see it mentioned differently. So if there is an element of vasoconstriction, that increases the systemic vascular resistance, increases blood pressure, okay? This is something not related to the acetylcholine, صح? Can anybody tell me the mechanism? Why you will see a rise in blood pressure if somebody is being sort of intoxicated by indirect acting cholinergic agonist? One of the earliest، عشان كذا أنا حطيت السلايد الثانية هذه. ها؟ فين؟ هنا. أيوة. أيوة تفضلي. لا there will be no time for RAS. You mean RAS system sort of trying to compensate for the, لا, that's not. There's something faster. ها؟ لا. ها؟ What is this? Yeah, if you have acetylcholine build up, okay, don't forget that acetylcholine not only work here, acetylcholine will work on the autonomic ganglia, صح? So it's going to increase the transmission of both systems, the sympathetic as well as parasympathetic. يعني now we have gone beyond the picture that characterizes by the cholinergic agonist, okay? If you're having so much acetylcholine, then it's going to stimulate the autonomic ganglia, and another system will be involved. يلا sympathetic nervous system معانا, okay? And again, don't forget the adrenal medulla is very rich source of epinephrine, norepinephrine, and gets stimulated by acetylcholine, isn't it? So basically now you're having both systems are overactive. So in case somebody gets intoxicated by insecticide, because this is the toxic situations, not somebody's taking the therapeutic dose of peridostigmine, for example. No, we're talking about nerve agents. We're talking about exposure to insecticides, the toxic agents. Okay, once you're having some toxicology situation, then acetylcholine is going to produce something else. So if you see the patient having, for example, slow heart rate, but for example, after a few hours, blood pressure is high, and you as a treating physician don't think, oh, my diagnosis is wrong. No, your diagnosis is right. This is again organophosphate exposure. But the problem is what? You're having actually your physiology. You need to know your physiology very well. This is part of the pathogenesis that happens because of the toxicity situation. Okay, but they say at high or at toxic doses, basically the parasympathetic picture dominates over the sympathetic. But in case if you see something related to the sympathetic nervous system, don't be surprised. Okay, like what will happen to the CNS? If you are having a low concentrations, not low, yani, I mean that yani, therapeutic, within the therapeutic range of maintaining acetylcholine concentration, you will see actually alertness and increased concentration, and that will help with your concentration. But if you are dealing with a toxic situation, okay, then the acetylcholine is going to definitely, it actually has got a complex signaling mechanisms with too many neurotransmitters in the brain, and they might have convulsion, coma, and the convulsion itself is enough to actually to shut down the respiratory center and respiratory arrest. Neuromuscular junction, what will happen? If you are building up acetylcholine, what will happen? Yeah, increase contractility of the skeletal muscles, which is good, all right? But too much acetylcholine, what will happen? Ah, too much acetylcholine. Fibrillations of the muscle fiber, you will not see it by itself because this is actually a contractility of a certain muscle fiber. But fasciculations, something that you can see by your eyes because it's a group of muscle fibers are contracting together. So you can see it on the skin itself, okay? There will be a situation of called depolarizing neuromuscular blockade. Okay, what does that mean? It means that by giving acetylcholine with so much concentration, it will produce, the action potential phase one, it's the depolarization phase with the entry of sodium ions, okay? So basically there will be depolarization because acetylcholine is there, but there will be no repolarization because acetylcholine concentration is so high. So the muscle will undergo a block. We call it phase one block. Depolarized cannot repolarize back again, all right? And that's why they say this actually phase one block is followed by phase two, which is a desensitization. Yani even when it repolarizes, it is no longer sensitive to acetylcholine. So if it loses sensitivity to acetylcholine, what will happen to the muscle? It will not contract. يعني إيش اسم الله? What is the other name for it? Yes, excellent. It will undergo paralysis. Okay. Do you see now how many mechanisms of death we can have if somebody has got exposed to nerve agents or a toxic dose of neuro insecticides? I hope that it's clear to you. Now, whether we are talking about direct or indirect, طبعا not the insecticide and organic phosphate, we're talking about neostigmine, peridostigmine, edrophonium, and bithacholine. These ones are the cholinergic agonists. In which situations we need them? What are the clinical indications? Yalla. Where we use them? In the eye? Do we use them in glaucoma? شلون no? Yeah, I've just told you that they produce meiosis and increase احنا لساتنا في الصباح يا جماعة ايش فيكم؟ Okay, we said that meiosis as well as the accommodation reflex, right? It would make the aqueous humor flow easier in the eye. So that's why we can use them for treatment of glaucoma or in meiosis. Very good. Second indication, after lens implantation with cataract surgery. Do you know what is cataract? الموية البيضاء. Okay. The cataract means the eye lens is opaque because of diabetes, old age, whatever. We need to take it out and put another artificial lens inside. Okay. How do you think that we can do that under local anesthesia? We need the pupil to be very, very wide, open. صح? So we gave mydriatic drops to open the pupil, take that lens, put the new lens, suture, okay, and then are you going to leave the pupil wide? Actually, even after the surgery for a few days before the healing process, they cannot withstand looking at very bright light. So it does help the patient that we cause meiosis only for 2 to 3 days until healing process happens and then the lens can see properly, okay? So that's why after cataract surgery, we might need these eye drops to cause meiosis to help or to spare the patient from seeing halos of light or being very uncomfortable with the bright light after the surgery. Clear? Yeah, and for that reason, we use pilocarpine. Pilocarpine has got a more sort of effect towards the towards the eye itself and the glands. GIT, genitourinary. In which situation you want to increase motility and relax sphincters? Sorry? Yeah, not the normal one, but there should be something very pathological and genuine that needs medication for it, okay? Because these medications are not actually, these medications are, I would say, dangerous medications. So, affecting heart rate and صح ولا لا? So you want to spare them to a very genuine situations. It happens after surgeries, post-operative ileus, paralytic ileus. It happens that when somebody has gone under general anesthesia and taken general anesthetic, these cause some atony. The muscles will not contract normally after the surgery because of the effect of the medication. This is a short-lived condition or temporary situation, okay? So they will have sort of this constipation, they're not moving their bowel. So what you want to do is to give them, some doses of methanicol, for example. It's very efficient and that purpose. So, but make sure that there's no obstruction. Not they are constipated because there is a mass or tumor or something like that, okay? So any situation, urinary retention, sometimes after prostatectomy, major surgeries, they just cannot contract, okay? And cannot empty the urine. So instead of doing catheterization every now and then, you can take these medications. Have you heard about Sjogren's syndrome? Sjogren's syndrome is an autoimmune disease that affects the lacrimal glands and salivary glands. They have dry eyes and dry mouth. You want something that works on the glands and make them secrete more secretion. What is that thing? There must be cholinergic agonist here that helps. But we will choose again the agents that are more selective to the glands rather than the heart. Do you see what I mean? There are certain subtypes. So pilocarpine is a very good agent for the glands. But some people, they say pilocarpine causes excessive sweating and civimylin is more to the lacrimal and salivary glands. So there are little differences that I will not ask you about the exam, but just know that we do have like 2 options for Sjogren's syndrome. Have you heard about myasthenia gravis? Yes. What is myasthenia gravis? Yeah, this is an autoimmune disease by which they have actually weak muscles because they have autoantibody occupying nicotinic receptor and will not allow acetylcholine to stimulate the muscle to contract, okay? In order to treat myasthenia gravis, you need to increase the bioavailability of acetylcholine. And we do that by neostigmine or pyridostigmine, one of these medications that I've told you. Do we have now the adverse effects? Can I continue ولا تعبتوا تبغوا بريك؟ ما عندي مشكلة في anything. بريك؟
يا بدهم بريك.
سمعت بريك، اتفضل خلاص 10 minutes إن شاء الله.
I'll be right back if you need anything.
Yeah.
Okay.
طيب. السلام عليكم ورحمة الله. Shall we resume? Um, so we shall continue now with the cholinergic agonist lecture. The last two slides is about the adverse effect. Basically, whenever you give more dose from what you require for a certain therapeutic effect, you will be actually going into the range of adverse effect. Okay, يعني for example, you are giving them to enhance contractility of the gastrointestinal tract. Okay, for paralytic ileus, for example, what will happen if you are giving too much? You might have bradycardia, you might have bronchospasm. This is basically, so it's the same table that will show you the therapeutic effect, as well as if you are actually exceeding what you need to give for the patients and what will happen afterwards. But there are certain toxicity situations where we might actually see cholinergic agonists are coming on board, or clinically in certain scenarios. One situation from each, one from the direct, one from the indirect. The direct acting muscarinic stimulant toxicity is actually the most important example is inosite type of mushroom poisoning. You know that I've explained to you muscarine and how is it a natural alkaloids and highly lipid soluble, so absorbed very quickly, and produces a similar picture to all the effect of acetylcholine. All right. So now we have to know that where actually muscarine exists, one of the richest sources of muscarine is a genus of mushroom called inocybe. And this inocybe mushroom is not supposed to be edible. Okay, so basically when we want to eat mushroom, we know from where to get it, because different countries, they grow mushroom, but only the edible species, or the edible actually types, are harvested and sold in supermarkets. However, they might be finding a situation of accidental exposure, okay, or sometimes in poor countries, somebody might take it and eat it. So inocybe is a type of mushroom that contains high concentration of muscarine and other alkaloids. And if it is consumed, you will have all the signs and symptoms that is actually mimicking acetylcholine accumulation in the body. So they will be having nausea and vomiting. From where the nausea and vomiting? It's not a mechanism that I explained. It's not in the table, nausea and vomiting. GI, okay, هو طبعا دخل GI بعدين where does it go to? Does anybody know what is the chemoreceptor trigger zone? Chemoreceptor trigger zone, which is a center that is closely linked to the, or part of the medulla, but it's outside the blood-brain barrier, and it is in connection with the vomiting center, right? Why, when you take any medicine, it might cause nausea and vomiting, even if that medicine does not cross blood-brain barrier, صح? Because from the gastrointestinal tract, once it is actually absorbed, it will be carried by the blood, and this is a region actually of the CNS, but it's outside the blood-brain barrier, so it can go to the chemoreceptor trigger zone, and we have different receptors in that area. And one of the receptors, we have opioids. That's why opioids, they cause nausea and vomiting, histamine, serotonin, enkephalins, and acetylcholine. Okay, so basically you have cholinergic receptors in the chemoreceptor trigger zone. So now my medicine is something similar to acetylcholine. I've absorbed actually that meal, and once it circulates and reaches chemoreceptor trigger zone, then the patient becomes actually nauseated and vomiting. So this is part of the picture itself. Diarrhea, we know why. Huh? Because increase the motility of gastrointestinal tract, صح? Urinary urgency, because the contraction of the urinary bladder and relaxation of sphincter, they cannot hold the urine. This is what we mean. Salivation, sweating, أكيد, right? Cutaneous vasodilatation, acetylcholine actually can cause skin blood vessels to vasodilate, so they'll be like flushed, and cutaneous vasodilatation. Bronchial constriction, we know how it happens. Akid, this is the effect of acetylcholine on the bronchial tree, and that will develop very, very quickly. And the how we treat that, we give the cholinergic antagonist that we have, which is the most important atropine. واضح؟ طيب, one example for the indirect acting cholinergic agonist, that happens with organophosphate. This is the situation where toxicity happens. Either the major source of toxicity is either exposure to pesticide or insecticide in agriculture. There are certain brands from the insecticide that are put in the table for you. In the United States, for example, they cannot sell them to anybody. يعني إذا مثلا أنا say for example I come and I want to buy them because I have a farm, they will not actually sell them because sometimes they are very toxic to humans, not only to insects. So unless this is a licensed person and they know how to actually pay attention to the details, protecting themselves, specific clothes, spray from a distance, don't breathe in and leave the site where actually you spray them. So you will get situations of intoxication because the individuals are not actually careful on not applying the instructions. And definitely in chemical warfare agents, Soman gas, sarin gas, VX, Fitabone, other actually nerve agents are being used, and this is against the Geneva Protocol, and this is completely unethical, but it happens, and the individual will present with the following. This is again repetition. Small pupil. This actually helps in the diagnosis. When they come to the ER, once you see them, you look at their pupil, you will know that this is actually an important sign. The small pupils. Salivation, sweating, bronchial constriction, vomiting, diarrhea, cognitive disturbance, because now we have gone to the extreme of toxicity where too many neurotransmitters are being involved, convulsions and coma. And don't forget now, we are having so much concentration of acetylcholine that causes this depolarizing neuromuscular blockade. What I've just explained, that initially that acetylcholine is going to cause depolarization, but because it's too much and cannot actually leave the endoplate, so it's going to lead to a phase 1 block. So the muscle will be blocked in depolarization, will not repolarize, okay, for some time. This is the period where you will see fasciculations. When it repolarizes, it becomes insensitive. So it's not responding to acetylcholine and the muscle will become paralyzed. And one of the most important muscles for the breathing, the chest muscles, intercostal muscles, most importantly, the diaphragm is a very important skeletal muscle that helps with the breathing, okay? So can you tell me now, what are the mechanisms of death in these situations? How many mechanisms we have هنا؟ أيوة. كله تحته خط يعني. Which one actually can kill from these? Depolarizing neuromuscular blockade, yes, because the muscles of the chest and diaphragm, they might be paralyzed, so they're not helping with the movement of the chest wall of the breathing. Yes, this is one mechanism. Yes, bronchial constriction. The bronchioles are narrowed and too much secretions blocking them. This is the second mechanism. The convulsion itself, yes, it compromises breathing and yes, convulsion is important. Okay, so these are the 3 important mechanisms of death. How we treat these patients? طبعا, in case that they seek medical advice, then we have to give the cholinergic antagonist, which is atropine. We have to give repeated doses of atropine for them. And diazepam is an agent that we use for convulsions. And we have an antidote, which is a pralidoxime, that حيجي إن شاء الله نتكلم عنه في next lecture. تمام? Now, cholinergic antagonist, what is the most important agent, as I told you? Atropine. Atropine is a very important agent as considered the prototype medicine for being a cholinergic antagonist. And it is derived from plant called Atropa. Yani that's the name came from the plant Atropa belladonna. The whole plant, actually, still there are cases in the literature of toxicity with these plants because it can be grown anywhere and it is very attractive in the looks and has got berries. Do you see this part? This is the fruit actually, and is sweet in taste like البيري نفسه, فممكن واحد يشوفها يعني okay, start eating it. And there are cases of death that has happened because of intoxication of this plant. Can you give me the mechanism of death? Yes, the most important now is the opposite to the heart rate that happens. Okay, we said acetylcholine is going to reduce heart rate because it's rest and digest. Okay, حفظوها بهذه الطريقة. All right, but now it's going to do the opposite. So stimulating the or blocking the acetylcholine effect on the SA node and AV node, they will have tachycardia. And usually individuals, they can manage with having fast heart rate, but the fast heart rate in certain individuals sometimes can cause decompensation, heart failure. Sometimes it can trigger a certain type of arrhythmias, and then patient will die. Okay, so we call them antimuscarinic. Cholinergic antagonist. We are talking about antimuscarinic because we have antinicotinic, because different receptors, they can be antagonized by different agents. Atropine is the main or naturally occurring antimuscarinic agents, and present naturally, and is from a deadly nightshade and plant grow in the dark. And what is belladonna means? And they call the plant Atropa belladonna. Belladonna means beautiful woman. Why do you think that is related to atropine? ايش الحاجة اللي beautiful؟
People will think about eating it.
لا.
Dilating the eye.
الاي يس واحدة من البنات قالت ايش فيها الاي؟
Dilating the pupils.
Yeah, because one of the oldest, thank you very much. Yes, this is the correct answer. Because one of the earliest indications for using atropine from that plant, that they used as eye drops to dilate the pupil, all right? And the dilated pupil becomes black, and black is beautiful in Western population, Western culture. So the mechanism of action is as simple as reversible blockade or competitive antagonism. Too much acetylcholine needs adequate concentration of atropine. And this is important. I need to tell you this because the concentration is important. Why? Because in therapeutic situations, yes, a small dose of atropine, 1 or 2 milligrams is adequate to cause the effect that you want. But if somebody is coming with nerve agent intoxication, they're actually having a sort of too much acetylcholine bioavailability in their body, and works for quite a long time. So they need repeated doses of atropine, and don't forget to repeat giving them repeatedly. Atropine selective to muscarinic receptors. All right, we do have muscarinic receptors in too many, as you recall from that table, salivary glands, bronchial, sweat glands, whatever, but not all of them can be antagonized fully by atropine, because it has been found that gastric parietal cells cannot be antagonized by atropine. That's why if you are thinking that I might be using atropine for peptic ulcer, then no. واضح؟ يعني hydrochloric acid is part of the gastric secretions that happens in response to a meal, صح? If you want to block that because that patient has got peptic ulcer disease, no, that will not happen. The examples here in this table, we have tertiary amines or alkaloids. These are the more lipid soluble, and we have the quaternary amines, which are less lipid soluble. We have natural and we have synthetic. Atropine is the prototype drug, and half-life is 2 hours. Hyoscyamine is an isomer of atropine, and that's levoatropine, and works for 3 to 5 hours. Scopolamine, or the other name for it, hyoscine, works for like 3.5 hours or something like that. Tropicamide works for 4 to 8, and benzotropine 12 to 24 hours. Ipratropium works for 2 hours, short acting. Tiotropium is very long acting, 5 to 6 days. Okay, half-life is not required from you, but when I say that something is alkaloid or tertiary amine, that means it's well absorbed from the gastrointestinal tract or from the conjunctiva, or as transdermal patch if you wanted actually them to reach the systemic circulation, especially the CNS. Quaternary amines, they are not going to be easily absorbed from the gastrointestinal tract, and these two specifically, you need to know them very well because these are used in bronchial asthma. Why we use Antimuscarinic agents in bronchial asthma. Yeah, if I was able to do them as inhalation, which is ideal. Okay. Okay, vasodilation. Yes, because acetylcholine causes a bronchoconstriction. Now you are antagonizing that, and you have succeeded to make it as inhalers. Yeah, and that's even much better than giving them on by systemic route of administration. So ipratropium and tiotropium are very important treatment bronchial asthma. And because of the difference in half-life, which one I use in acute attack and which one I use for chronic management? Because ipratropium is 2 hours, short acting. It's very good when he is coming now in ER with asthma exacerbation. But the tiotropium is an inhaler he can use at home because it's very long acting. He can use it daily to prevent the new asthma attacks. Excellent. Atropine half-life is 2 hours, but in the eye, it can persist for, sometimes it's binding with the tissue. It can bind, it can persist for more than 72 hours. Now, you remember the table that we have? Now we are going to put the opposite. Yes. We will revise. CNS, what is the effect of acetylcholine? Excitation, important for learning, memory, صح? Alertness. Now what will happen here? Sedation, okay? Drowsy, cannot remember, amnesia, and sleep as well, okay? But again, you please remember that if there is a toxic situation, we will go beyond this table and we can see, because too many neurotransmitters are being sort of linked and connected to each other. So you might see excitation and hallucinations and seizures, or sometimes coma, because too many actually neurotransmitters being sort of interfered with. The eye, acetylcholine used to do what? Meiosis and accommodation reflex. It makes you actually able to read, all right? Here, what will happen? Mydriasis, the opposite. Cycloplegia, that means the ciliary muscles are not actually contracting and making the lens convex for reading, okay? And again, don't forget the lacrimal glands. Acetylcholine make you lacrimate or have tears, hina, dry eyes, exactly, okay. So how do you think that will affect the vision? Can you read under the effect of atropine or antimuscarinic? Yes, that's why when they mention a certain medicine has got an anticholinergic effect, and when they list, they will tell you dry mouth, okay, and they will tell you blurred vision. Blurred vision, that means when you try to focus for something new, you cannot see properly, okay, not for the far, for the new. Heart, acetylcholine bradycardia hina, tachycardia. Bronchioles, acetylcholine bronchoconstriction and freeze secretion. Here, dilatation and reducing. This is ideal for asthma and COPD. صح? This is part of the treatment of asthma and COPD. We give antimuscarinic agents. GIT, yeah, salivation. طبعا هناك كان في salivation, increased gastric enzymes, motility, relax the sphincter. Here is the opposite. To relax the muscles, reduce the secretions, contract the sphincters, okay? But they say here, so these agents are going to produce constipation, right? But there is something here very genuine, that they say the intestinal paralysis will be temporary only for 1 to 3 days. Why it will not continue? Does anybody know? لا مش desensitize, ما في desensitize. No. Anybody remembers what's the third division of the ANS? Enteric, yes. So we have an autonomic nervous system local to the GI itself, okay? So it can give actually a signal. It functions actually in sort of independent from the brain itself and the neurons and the ganglion, autonomic ganglion that I've explained to you. It's actually within, it can feel something within the lumen and can act on it. So it can feel that there is a buildup of waste products, we need to excrete them. No more constipation, subhanAllah, okay? Genitourinary, what will happen? Relax the detrusal muscles, okay, and contract the sphincter, so they will hold the urine. And sweaty glands, they will not sweat, okay? Hina can feel too much sweating. Now you are preventing sweating. How do you think that will affect your body temperature? Yeah, it will increase because sweating is a cooling mechanism by which our body needs to do to acclimatize with hot weather, because we need our body temperature to be 37, not more than that. So we need to evaporate that water and sweat in order to cool our body. So if we are preventing sweaty glands from doing their job, then somebody will become febrile. Okay, excellent. Now, what are the uses? Very easily. CNS. Anybody knows what's Parkinson's disease? Don't worry, you will take it, inshallah, second semester with the neuro block. Parkinson's disease, a disease of muscle rigidity, bradykinesia, and slow movement, because there is disbalance between dopamine and acetylcholine. This is actually what happens. In Parkinson's disease, dopamine is low, deficient. Okay, so acetylcholine, although that did not actually change, relatively it is high. So what I can do is either that I will treat Parkinson's disease by giving dopamine or by inhibiting acetylcholine. So this is actually part of the treatment of, if you do not know, then inshallah, second semester in Euros, you will have actually maybe 2 hours about treating Parkinson's disease. Motion sickness, anybody knows what's motion sickness? الناس اللي بيجيهم دوار البحر وهذه الأشياء. What is the reason for that? Very sensitive. There are certain individuals. The motion sickness is because of the signal that the brain is getting from the eye and the ear. Okay, ear is very important for balance, and eye, of course, طبعا عارفين for what. If you are actually on a boat traveling, okay, or on train, the eye see everything to be steady. صح؟ ما في حاجة مقلوبة. صح؟ Everything is steady in front of your eyes. However, the ear feels that you are actually moving or traveling. Having 2 different signals to the brain will think you are intoxicated with something, and that is affecting your senses. So it will stimulate this vomiting reflex, nausea and vomiting, subhanAllah, to protect you, because needs you to expel whatever has caused this issue. This is what the brain interpretation. Okay, so now what we need to do for these individuals, if they want to travel by train or by car or by the sea or by boat, okay, they need to take something that is something like scopolamine, lipid soluble, that will block acetylcholine receptors in the chemoreceptor trigger zone, as I told you, because chemoreceptor trigger zone is very connected with vomiting center, and this is something going to reduce this vomiting and nausea. If you block acetylcholine receptors in the chemoreceptor trigger zone, then it's going to relieve the situation. You can't travel, especially scopolamine. Okay, despite the fact that it's not actually very long acting, but we have scopolamine because it's lipid soluble as patch, transdermal patch. And this transdermal patch can work for 2 to 3 days. Okay, طبعا this is ideal. يعني if somebody wants to go for a cruise في البحر مثلا, okay, let him put that patch, doesn't need to worry about tablets, all right? So the patch will maintain a certain concentration of scopolamine for motion sickness. For the eye, why do you need the pupil to be dilated? If you want to examine the retina, صح? Diabetic individuals, they get retinopathy. They go actually and see a certain diabetic actually retina clinic every 6 months or every 1 time per year. The ophthalmologist cannot see the retina clearly without dilating the pupil. So you will give eye drops to make the pupil white for some time, and then يعني خلاص the effect will fade away. Assessment of refractive error in uncooperative patients. If you are going to an ophthalmology clinic or to an optometry, I would say a clinic, and to have your prescription checked, you will need to focus on a certain object in front of you. صح? The doctors having actually a difficult time with children, because when there's a small child and you want to check the vision for the child and ask him to look at that sort of figure or that diagram or whatever, the child will not actually cooperate. صح? يعني it's very difficult to handle children. So what they need to do is that they give these eye drops to dilate the pupil and cause cycloplegia for the child, only for some time, a few hours. What will happen? And how is that going to help him to test his vision? He will not be able to see the near object. صح? because we need the ciliary muscle contractility and the convexity of the eyelids to look at near objects. If you put these eye drops, they're going to produce cycloplegia, so they will not see what is around them. He will not see his mom, he will not see the doctor. So he will cooperate and look at the far objects, okay, and tell you what he can see. So this is a little bit of a trick, but it does help an ophthalmology clinic to handle these individuals. COPD and bronchial asthma, you know that very well. If you want to increase the heart rate, طبعا in resuscitation situation where the patient is bradycardic, you give atropine, heart rate becomes high. GIT, if there is excessive diarrhea, that's the opposite, صح? If you want to stop that diarrhea, طبعا this is not actually ideal because you need to look for this source of infection and treat it, okay? But in case that you are treating, yeah, but you want actually to relieve and, you know, to handle this dehydration that is happening because of excessive bowel motion, you can use anticholinergic or antimuscarinic agents. Urinary disorders, urinary urgency, bladder spasm by different, and urinary incontinence. What happens now in certain infection, if somebody has got cystitis, the bladder is so inflamed that cannot even hold the urine, okay? So he cannot hold the urine. Every now and then he will go to the toilet to pass urine. You need to increase the capacity of the bladder by giving antimuscarinic agents, طبعا with treating the source of infection, okay? Again, sometimes happens after prostatectomy or some after procedure, when there's a spasm of the bladder, you need to do the opposite. So it depends on what you want. If you want contractility, you will give betalicol, for example, okay? If you want relaxation, you will give antimuscarinic agents. And of course, cholinergic poisoning, whether it is an mushroom poisoning with inosite, and they are actually having so much, they have absorbed so much concentration from muscarine, I will give atropine in these circumstances. If it is a nerve agent or organophosphate poisoning that has happened, I will give again atropine, repeated doses, because you do not know actually how much he was exposed to. Maybe he has too much in his body, so you need to give atropine repeated doses. And atropine, we prefer intravenous and IV route of administration because that's actually more suitable for emergency, intravenous and repeatedly. And we have an antidote called pralidoxime. Pralidoxime is an agent that breaks the bond between the organophosphate and the cholinesterase. So we call it like a regenerator, enzyme regenerator. It's going to break that bond, restore the enzyme, and the enzyme will be able to handle acetylcholine and metabolize it in the body. واضح؟ طبعا pralidoxime is one of the agents that we need to give it very, very quickly before aging happened to the bond, all right? But there are certain case reports saying that even if the patient presents late, after 10 minutes, you still can give pralidoxime. Repeated doses might be able to split the bond between the cholinesterase and the enzyme and regenerate the enzyme back for you, okay? Yani it's not like, yes, and we understand that the aging will happen within 10 minutes for some agents, but it is worthwhile trying whenever the patient has got an access to the hospital after intoxication. The only here situation about toxicity situation with atropine. Do you think that atropine poisoning is common? Atropine is not something that is orally, yani, there are certain oral preparations, but they're not actually very commonly used. So mainly atropine, you will find it in hospital environment, okay? As IV for, yani nobody will sell atropine in pharmacies, for example, okay? So atropine is one of the medicines that are only, you will find it predominantly, I would say, in hospital environment. So which situation somebody will have atropine poisoning? أيوة صح. Yes, this is very important. When it happens outside the hospital, she is very correct, that it's because of somebody has gone walking about and they have seen these beautiful berries and they've taken them. صح. This is common. Exactly, by mistake. Okay, somebody's giving more than the required dose by mistake. Okay, that happens accidentally. Okay, sometimes they say healthcare professionals, they want to attempt to induce hallucinations. And somebody who wants to abuse the atropine, because we know that toxic concentration, you remember, it can produce hallucinations and, you know, some effect. So maybe somebody يعني like مثلا doctor ولا nurse who knows about the pharmacology, so they will take it and abuse it. Okay, so this is actually what happens. And the clinical features, they will have extreme dryness, you know, because the pupil are going to be wide, heart rate, and this is actually the thing that's dangerous, that's going to they will be tachycardic, and they will feel, why they feel hot and flushed? Because it inhibits sweating, صح? Agitated and delirium, this is part of the CNS toxic features. Do we need to do something about them? لا تقولوا لي نعطيه مستالكونين. ها ما في bond. He has taken atropine بس. صح؟ Atropine, remember the half-life of atropine. How long is it? 2 hours. Okay, يعني by the time you're actually taking history and doing some supportive treatment will be metabolized. So you do not need an antidote, basically. You just need symptomatic treatment. They say cooling blankets and something to cool body temperature. You can give diazepam if he's having seizure. Diazepam is a sedative agent that works on the CNS. So يعني just give symptomatic treatment. Don't give antidote. Don't ever think about giving cholinergic agonist. We have lots of issues with cholinergic agonist. And this is going to be only 2 hours and will be metabolized. Okay. Last thing is the antinicotinic drugs. Okay. Certain tribes from South America, they use actually a substance, they derive it from a certain trees to kill the animals and will help them in hunting. Okay. What is that substance? They coat their arrows with it. This is actually a poison called curare. This is a poison that has got an anti-nicotinic activity. Okay, so that's something works on the nicotinic receptors at the somatic nervous system. So curare is the name for the poison that certain South American tribes are using to coat their hunting arrows to facilitate hunting. And the active substance, it was actually isolated in 1940 and identified that it can be used in medicine, and tubicurarine. That's the name of the substance. What are these? These basically, they're structural analogs to acetylcholine, and they're going to block the cholinergic neurons at the skeletal muscles, at the motor endoplate. Okay, so anything that blocks acetylcholine receptor at the neuromuscular junction or at the skeletal muscles, what do you expect will happen to the muscle? Yeah, the muscle will be paralyzed. Exactly. Okay. So why do you need to produce paralysis? يعني احنا we said identified, introduced to medicine 1940, happy with it وهالكلام هذا. Why do we need to produce paralysis for a patient? No. Surgeons need to produce paralysis in general surgery. Why? Because if somebody is anesthetized, general anesthesia, anesthetized totally, in orthopedic surgery, you need mobility of the patient. You need the, if you are replacing the knee or the hip joint, you do not want the muscles to resist you when you are actually doing your job in surgery. Okay, so you need actually flaccid paralysis for all the muscles in the body. And don't worry about breathing because they are already connected with a ventilator. Okay, so the breathing is done by a ventilator. No worries about that. Okay, but you need mobility of the patient on the operating table. So that's one indication. The other indication is for endotracheal intubation. If you want the patient to be anesthetized, once you give them the general anesthetic intravenously, you need actually to connect them with the endotracheal tube and laryngoscope. This is إن شاء الله كل هذا الشيء هتاخدوها. Laryngoscope and endotracheal tube. You want to put that into their larynx, connect that with an ambu bag and the ventilator. That's part of the anesthesia that they are doing, all right? In order to introduce that to the airways, you need an extreme sort of flexion, extension of the neck itself. You need to position the patient in such a way, okay, to facilitate this process. And for that reason, you do not want skeletal muscles to resist you. I think the skeletal muscles are quite strong and resisting this thing. So if he is paralyzed, okay, very easily you can mobilize him the way you want in operating theater. And these are short acting. Once the surgery is done, they stop the anesthetic, they stop the neuromuscular blocking agents. واضح the reason why we want to produce paralysis? That's the only reason, okay? طيب, they are classified into two categories, non-depolarizing and depolarizing. Depolarizing, هذا هو التيبل. We have one depolarizing agent which is called succinylcholine. Okay, succinylcholine is the only depolarizing neuromuscular blocker. It works similarly than to what I told you about the acetylcholine accumulation and how it produces paralysis. And for the non-depolarizing, we have cisatracurium, pancuronium, and rocuronium, and too many actually that belongs to this class. The pharmacokinetics, the succinylcholine is introduced or given by intravenous infusion because it has got a very short half-life, because once actually it's given, it will get hydrolyzed and redistributed by plasma cholinesterase. There is certain enzymes in the plasma called plasma cholinesterase that will degrade succinylcholine very quickly, so the half-life is within minutes. But these ones, no, they can maintain an activity for 45 minutes or 1 hour. So we can give them as IV bolus, and then if you need more, depending on the duration of the surgery, you can give an intravenous infusion. And the action will be terminated by redistribution hydrolysis. What's the mechanism of action? When I say depolarizing, that means they do something similar to acetylcholine. Acetylcholine, what does it do? Depolarize the muscle, okay? So this is basically what they're going to do. It's going to cause depolarization in the muscle, which is phase 1, entry of sodium ions, and that will lead to a transient muscle twitch. You can see some fasciculations on the patients, but it will undergo this persistent depolarization, will not be reversed by repolarization, and the muscle will lose sensitivity to acetylcholine and it will be paralyzed. That's the mechanism of action of succinylcholine. But why we like it, although that this mechanism is a little bit complex, we like it because it's short acting. Because in surgeries, the anesthesiologist will work with the general surgeon, and the doses that he's giving from the general anesthetic and muscle relaxant, they call them, depends on the duration of the surgery. If the surgeon is about to finish, he will tell the anesthesiologist, I am about to finish, by the way. So he will finish very quickly because there's no time for recovery. Once the surgery is over, you want the patient to recover and go to the other patient, attend the other patient, because you have a full schedule in OR. Okay, Banat? The mechanism of action of the non-depolarizing, they are just blockers. They block the acetylcholine receptor at the nicotinic receptors and prevent depolarization. So they are preventing acetylcholine from producing depolarization and muscle contractility. Shall we stop now? Time is over and I have only few slides بس هتاخد وقت. Would you like me to record that and send it over to you? ولا... Okay. Do you think that the lecture was quick? ولا the way I progress is, speed is fine? طيب okay. الحمد لله. مين الليدر هنا؟ عشان ابعث الريكوردينج. ممكن بس الاسم في ورقة كذا صغيرة تدوني يلا عليكم. ليدر والايميل. ولا ابعثها المنتصر ولا مين اللي اي خلاص. Do you have any questions? By the way, this lecture needs you to study everything together عشان تفهم, right? I understand that sometimes when I ask a question, يعني I'm pretty sure that inshallah all of you are excellent students, but you cannot answer because you did not study the material, all right? So that's why I stop now. يعني there's no point of actually giving you يعني this is your break time and you need to relax. So it's better that you read right from the introduction, know your physiology and anatomy, study the cholinergic agonist. Yeah, it's not supposed to be like this بس الجدول يعني you need to study everything separately. Once you study cholinergic agonist, it will be very easy to study cholinergic antagonist. Okay, so inshallah study those lectures and make sure that you study them during the weekend before you take the sympathetic. It makes your life easy. Okay, so study these inshallah. I'll send the recording for the last 2 slides to you during the weekend. That will continue. If you have any questions, you can ask me by email. I don't have any issues. If you have any questions now, you want me, I'm free. هذا مين فرح؟ خلاص ان شاء الله. اي تفضل.
I literally have to exactly say this is not important. These are not these are not important صح؟ بس
لا ما تحفظيهم انت.
اوكي بس then how will I know the examples لكل واحدة if I didn't memorize them؟
لا يعني انت بتعرفي ان الادريفونيوم very short acting.
يعني I don't have to know everything is this one.
لا اوكي الادريفونيوم works for 5 to 15 minutes.
أحفظ
ليش؟ السبب
ولا
عشان
بس إنه short؟
لا تعرفين هو short. ليه؟ because it makes hydrogen bond which is a
easy
weak
to-
bond
yeah.
and very easily breakable. That's what I want you to know.
Thank you so much.
Any other questions? Yes.
Thank you, doctor.
Welcome. يعطيك العافية.